exercise can help a diet be more effective. So formerly obese women, if they exercised afterwards, they were more likely to keep their weight off. If they did exercise, of that group, 90% kept the weight off. But if they didn't, only 33% kept the weight off. So a pretty dramatic difference. Prolonged weight change can shift the body's set point. So it's possible to reset sort of like what your body considers to be your set point for weight, and then your basal metabolic rate will try to preserve that new set point. So it is possible for a person to lose weight and maintain that weight loss. It's hard. I'm not saying it's easy, but it is possible, and then there's a new set point for that. Medication tends to not be as effective. Drugs that work through increasing serotonin or leptin and insulin or through decreased fat absorption have been promising but do not work for all patients, and all have significant side effects, right? And some of them are pretty substantial. So that's why there's not a huge push for medication being used for weight loss because of the side effects. Obesity has also recently been looked at as a form of addiction, and it's because there are some characteristics that we see in common between addicts and individuals who are obese. One of them has to do with dopamine and dopamine receptors. So in drug users, there is a corresponding decrease in dopamine receptors. And this is something that we see a lot, and it's another example of homeostasis. If you take a drug that boosts dopamine in your brain because of that rewarding effect of the drug, and you take it regularly enough, your brain is going to compensate for that. We're going to see something called receptor downregulation. Receptor downregulation means that there are going to be fewer receptors for that dopamine. Why? Because your body is compensating and trying to maintain homeostasis in the face of large amounts of dopamine because you're taking this particular drug over and over again. And so the same thing, food is rewarding, and a food produces dopamine, and in obese individuals we see a very similar sort of decline in the number of dopamine receptors. So here in this picture on the right, we can see the level of dopamine receptors, and with reds being a higher density of them, a greater number of them, and then yellow being a little lower and green lower. And we can see that in obese individuals there are fewer dopamine receptors than in the matched control group. So that is one of the things that's really interesting, and that we see being something in common between addiction and obesity. There are also peptides that induce eating that target dopamine neurons. So it seems like the dopamine system is certainly involved in eating and overeating. Anti-addiction drugs are showing effectiveness in weight loss. A combination of bupropion and naltrexone resulted in 50% more weight loss than a placebo. Don't get too excited though, because the weight loss was still very modest with these approaches. We're still looking at 5 to 10% weight loss, nothing that major. Now we'll turn our attention to conditions of being underweight, in particular anorexia nervosa, bulimia nervosa, and binge eating disorder. These are very dangerous conditions. So obesity has risk factors for sure, but anorexia and bulimia in particular are very, very dangerous, and they are not to be taken lightly at all. Anorexia is called the starving disease. These are individuals who restrict their food intake in order to maintain a target weight that is just unrealistically low. Interestingly, one of the questions asked, well, is don't they get hungry? Well, the answer is basically yes. They do have the normal hunger signals. So neuropeptide Y, which is involved in hunger and starting a meal, is high. Ghrelin, right, is high. So that's associated with starting a meal and your stomach growling. And leptin, the one that's released by our fat cells that keeps our weight, regulates our weight. If we were to start gaining weight, it would decrease our appetite and maintain our weight over the long term. That one is low. this is the recipe for being hungry, right? And wanting to eat. And so it's not that there's something broken in the hunger signals. It really is a condition where there is a strong emphasis on restricting food intake and finding that very rewarding ultimately. Bulimia nervosa is sometimes called binge and purge. So these individuals may binge eat and then induce vomiting as a method of maintaining their normal weight. This is also dangerous and has high relapse rates. Binge eating disorder, these individuals might eat very large meals, and they'll usually have high weight. So it's very similar, except they're not purging. There are certainly environmental contributions. There's a cultural emphasis on thinness in many cultures, and that seems to be a factor. So I want to show you here what we've learned from this study in Fiji. And when television arrived to the island nation of Fiji, it changed the preference of body type from being a traditionally full-figured individual, especially for women, from being fuller figured to what we see on television, typically thin women. And when that happened, there was an outbreak of eating disorders that they'd never seen before. So there is sort of this interesting connection between media images and what the perceived ideal weight might be and eating disorders. There are genetic influences in anorexia as well. Identical twins are 3 times more concordant than fraternal twins, so very big difference between identical twins and fraternal twins. Adolescent stress, hormones, and dieting may produce epigenetic changes in genes as well that can facilitate the development of anorexia. There's comorbidity with obsessive compulsive disorder and anorexia, and bulimia and depression. So these conditions are tied in often with other psychological disorders. There's also reduced serotonin activity. So selective serotonin reuptake inhibitors, these are serotonin agonists that increase the amount of serotonin in the brain. These antidepressants increase serotonin levels, right? They're agonists, and they seem to reduce binging and purging and improve relapse rates. So that's good. Reducing serotonin via food restriction may reduce anxiety and improve mood by reducing the activity of specifically serotonin 1A receptors. So this is important. In other words, it's having a different effect on one particular type of serotonin receptor, this 1A receptor. And these particular serotonin receptors are involved in anxiety. And so reducing serotonin and reducing activity at this particular type of receptor seems to be rewarding because it reduces anxiety. And so here we see a mechanism through which food restriction and basically not eating and self-starvation will be perceived as rewarding for the individual because of how it improves their anxiety symptoms. We also see that low activity in the cannabinoid system. And so the cannabinoid system is the one that we would normally think of as being associated with marijuana. So it's certainly a system that's tied in to mood and sort of psychological states as well as food, as well as the dopamine reward system. So decreased activities in these systems are going to mean that food is going to be less enjoyable, as well as other life pleasures are going to be less enjoyable. So eating also increases food-related anxiety in individuals with anorexia, and therefore food restriction, while it's not inherently pleasurable, reduces this anxiety and becomes very rewarding.